the organizing committee.
لا اللي مش موجود دكتور طارق.
I just want to give you some precision concerning my presentation. What I will probably do, actually, because of the time scheduling, is that I will present just the question of the adjuvant endocrine treatment in postmenopausal population, and during the second afternoon session regarding the ABC guidelines, I will focus on what is the strategy in the metastatic disease. So let's move to what is the optimal postmenopausal sequence of endocrine therapy in adjuvant setting. What is the best? And those are the different guidelines I'm involved. And just to say that sometimes, even in some guidelines, you have some discrepancies. But in any case, this probably have influenced the way that I've presented my results. The first background I want to come on, it's the results from the EBC-TCG overview conclusions. When you look at what happens during the first step of the adjuvant endocrine treatment with tamoxifen, we clearly have several conclusions. The first one is that giving an endocrine treatment is better than not to give. And the second one is that even if we give for a short period of 5 years, there is this kind of carryover effect showing you that you might benefit even when you stop the endocrine treatment for a risk of late relapse. So greater mortality reduction with approximately 5 years versus 2 years of tamoxifen. The risk for breast cancer death is decreasing of 0.7, suggests that in estrogen receptor positive disease, full compliance with 5 years of tamoxifen will also reduce the 15 years breast cancer mortality rates by at least a third and probably more if we look at the carryover effect. The question is, in fact, and this was mentioned by one of my colleagues that previously presented the situation in non-menopause population. What is the optimal estrogen deprivation? We know since the development of IA that they have provided an alternative strategy to deprive breast tumor of stimulation by endogenous estrogen in postmenopausal women. We also know that the first generation IEs, amiglutatimide, showed benefit in adjuvant therapy, but the fact was that the drug was too toxic. And we have today, with the third generation IEs, approaches nearly that complete the suppression of total body aromatization and plasma estrogen levels, with clearly better toxicity profile than the first generation. And they have all been studied as adjuvant therapy against tamoxifen in various series of randomized clinical trial, both as frontline treatment and also after tamoxifen. We have this presentation that has been made by Richard Pato during the internal meeting of the EBC-CTG that I have attended, and thanks to him, he just sent the slides remembering that if in absolute comparison, tamoxifen versus aromatase inhibitors, we look at the recurrence rate and we look at the breast cancer mortality, integrating the first generation trial of aromatase inhibitors versus tamoxifen, there is statistical difference regarding the improvement of recurrence, and there is also a statistical difference regarding the mortality. Even if it's small, the absolute benefit for the mortality is 1.5. But how to be sure that about the postmenopausal status? I just want to remember you how difficult it is sometimes in our everyday practice. In the very recent publication of the SOFT trial, if you go directly to the supplement of the New England Journal of Medicine, you will look what is the definition of a non-menopause, the premenopausal status. Regular menses without exogenous hormone during the prior 6 months, and or estrogen level in premenopausal range. And for patients who had completed chemotherapy prior to entry into trial, they were required to have a premenopausal estrogen level. So this definition is clearly not the definition that the gynecologists use widely. On the other part, there is a formal consensus statement about the definition of postmenopausal status. No regular menses without exogenous hormone during prior 1 year or prior 2 years in case of adjuvant chemotherapy, and in this situation, estrogen level not in the premenopausal range. So there is a clear percentage of patients who are not defined to be clearly premenopaused and who are not defined to be clearly postmenopause. And for some situation, we are in this kind of gray zone, and it's very difficult to have any status about the way we will treat the patient. So the first conclusion is that the adjuvant endocrine treatment is a key strategy in estrogen receptor positive breast cancer. Initial optimal duration of treatment was considered to be 5 years according to the tamoxifen data. The maximal estrogen deprivation is more effective, but do we need to define different strategies according to different risk, integrating tamoxifen also in a sequential way? A prolonged effect of initial endocrine therapy influences late relapse and mortality, so the optimal duration might also be defined, and there is for some patients a level of uncertainty regarding the menopausal status and the possibility to use IEs. So what is the optimal treatment sequence for the first 5 years? And let's look to all the trials we have. You see here that we have two groups of trials. The first three, the ATTACK, the BIG, and the TEAM trial, just addressing the question of the monotherapy versus tamoxifen. In those three trials, they are compared 5 years treatment of tamoxifen versus 5 years of aromatase inhibitors. In the second part of the table down, you can see several trials addressing the question of the sequential therapy, initiating with tamoxifen for mostly all the trials. You begin with tamoxifen 2 to 3 years, and then you switch potentially to aromatase inhibitors. There is only one trial, the Big 198, addressing the question of the upfront letrozole followed by tamoxifen, and actually the TEAM trial also addressing the question of the upfront exemestane versus tamoxifen exemestane in a sequence. When we look at the results, if you look at the different part of the tables, and particularly here if you look at the overall survival hazard ratio on the last part of the table, on the last row, you can see that when you look at the upfront 5 years of AE compared to 5 years of tamoxifen, there is some signal. The most important signal is from the big trial, but in general, we have no clear definition, no clear demonstration that there is an absolute and important overall survival improvement. However, the breast cancer mortality or free of interval disease is clearly increased when you use upfront aromatase inhibitors compared to tamoxifen. When you look at the second part of the table, when you look at the sequential trials, then we have more important signal regarding the overall survival. Does it mean that it's better to begin with tamoxifen and then follow the treatment with an aromatase inhibitors? It might be a very important problem regarding the methodology of these trials. When you look at the risk of relapse according to the nodal status, and you know very well this kind of curves, the lowest one is a node negative population, the upper one is a node positive. What happens when you address the question of the upfront treatment, 5 years versus 2 years, 5 years of aromatase inhibitors versus 5 years of tamoxifen? Tamoxifen are in the red boxes and the aromatase inhibitors in the green one. When you look at these kind of trials, they clearly take into account, since the time of randomization, the early event of relapse during the first period of 1 to 3 years, and then also after the 2 or 3 years. What happens when you look at the results concerning potentially the sequential one? In a lot of trials, like in YEASIT and the other one, the time of randomization might be clearly after the 2 years. So it was possible to include patients that have skipped clearly the risk of early relapse. And that means that you are increasing potentially the differences because actually you are just moving on the second part of these curves during the period of 2 to 3 years to 5 years. So the conclusion is that the upfront adjuvant aromatase inhibitors treatment is superior to tamoxifen in reducing early risk of relapse and improving overall survival, but there is no clear difference in efficacy among the drugs. We have actually several trials addressing the question, like FACE and EMA27, even if the level of evidence regarding overall survival seems to be more clear in the big trial. Switching to an IA after 2 or 3 years of tamoxifen is superior than to continue on tamoxifen, but early recurrences mainly comprised by distant recurrences. and the IBCSG-8 shows significantly superior disease-free survival. This is also a sequential trial, only from point of therapy switch and not from the beginning. That means that clearly we have to be very careful regarding the results of the sequential therapies in the adjuvant setting. What we know also about the treatment-related adverse events, and there is clearly an imbalance in favor of tamoxifen. We have more musculoskeletal events. Here you have the 3 trials, ATTACK, the BIG, and the TEAM-1. We have more events regarding cardiovascular events potentially, the bone mineral densities, and in general, that means that it's more difficult for the patients to have a good safety issue using aromatase inhibitors comparing to tamoxifen. So my third conclusion will be that in case of important early risk of relapse, and also one of the previous presenters clearly emphasized the importance of the nodal positivity, the high grade, the high Ki67, why not some molecular signatures, upfront aromatase inhibitor seems clearly reasonable. In case of upfront aromatase inhibitors, we do not have demonstration that switching to tamoxifen is better or deleterious. But we know that it is possible to switch to tamoxifen in case of important toxicity and in risk of non-compliance. Actually, this is what is recommended by several guidelines, ASCO guidelines, and also clearly by the St. Gallen guidelines. In case of upfront tamoxifen, switching to an aromatase inhibitors might be proposed because of the potential impact on disease-free survival and overall survival in some trials. So the last part of my talk will be devoted to the optimal duration of treatment after the first 5 years of treatment. When you look now, once again, at the last publication regarding the BCTCG meta-analysis, what we clearly know is that patients that have tamoxifen in the adjuvant setting, you can see here in all the curves compared to the control arm, benefit better. But if you compare those patients who have received chemotherapy or do not have received chemotherapy, it seems that the carryover effect is not exactly the same. That means that potentially, if you look at the risk of disease, if you better control the disease at the beginning with sometimes chemotherapy, maybe even in less endocrine-sensitive tumors, the influence of the early adjuvant treatment with tamoxifen in this meta-analysis is not so important for the late relapse compared to very endocrine-sensitive population that do not have received adjuvant chemotherapy. There is an influence of the chemo and the nodal status on late recurrence, as you see here, and there is also a clear influence on mortality at 10 years and at 15 years, as we mentioned before. So according to the EBCTCG publication, overall breast cancer population treated in the adjuvant setting with tamoxifen present an absolute risk of late recurrence after 5 years between 10 to 15%. This risk is higher in node-positive population who do not receive chemotherapy compared to node-negative with or without chemotherapy. And the influence of adjuvant tamoxifen is still clear between 5 to 10 years in the very endocrine-positive disease, but is less clear after 5 years in progesterone or estrogen receptor poor disease. So the risk clearly impacts the mortality. Do we have any signals concerning the extended tamoxifen treatment? This was previously mentioned. We have actually 2 trials. The first one is the ATLAS, the second one is the ATOM. The big differences between the both trials is in fact that in the ATLAS trial, all the patients were pre- and postmenopausal women with estrogen receptor positive, identified estrogen receptor positive disease who have already received tamoxifen for 5 years in the context of the ATLAS trial, about 20,000 patients. In the ATOM trial, the invasive early breast cancer have already been taking tamoxifen for 5 years, but we know just that 40% of them are estrogen receptor positive, and 60% of them are estrogen receptor unknown status. It's why ATOM is a negative trial, ATLAS is positive one, and the combination of both clearly demonstrate that going more than 5 years of treatment might clearly influence the control of the disease and the late recurrence. We also have some trial regarding the extended aromatase inhibitors treatment. The first one is the MS-17, the second one is the ABCSG6, and we have also the NSIBP33 trial which is actually ongoing. And what we know regarding the results, clearly, is that MS-17 clearly demonstrates, yes, thank you for the information, MS-17 clearly demonstrates an impact on disease-free survival, but not clearly on overall survivals, just in some group of high-risk population. ABCSG6 clearly demonstrates an impact on distant disease-free survival, but not clearly on overall survival, and we don't have the data on NSIBP33. So if you look now at the different type of treatment we have in the sequences, and if we integrate this extended treatment, you see that we have two kinds of situation. Patients that have received in the adjuvant setting 5 years of tamoxifen, then some trial addressing the question of extended tamoxifen, over one addressing the question of extended aromatase inhibitors. But we don't have actually any trial with any results for those patients that have received during the first 5 years aromatase inhibitors. So my conclusion at the end is that clinical parameters still remain crucial for evaluating the risk of late relapse, but also the importance of estrogen receptor pathway activation. The extended adjuvant treatment more than 5 years with AEs or tamoxifen benefit to patients at risk of late relapse, previously treated with tamoxifen, but we still do not know if it's the case for patients treated previously by aromatase inhibitors. Thank you very much.
Thank you, Professor Guilgros from France. And now I'm going to introduce Professor Deepu Tripathi from USA, who will talk us about new directions in combinatorial hormonal therapies.
Good afternoon. I'm going to move into the future a little bit, if you will, to talk about where we have been with hormonal therapies, particularly our understanding of the biology and how that has led to new paradigms using combinations of hormonal therapies with other targeted agents to maximize clinical benefit, and what I believe the future will hold in this area. It's first important to understand the genetics of breast cancer, which we are just starting to with the advent of newer technologies such as next-generation sequencing. This is